Good evening, sir. Am I audible?
Yes, you are.
Thank you, sir. We'll start with one review article paper, sir, on ultrasound imaging in critical care. This is the paper we are going to discuss, sir, right now, and we'll start with why should we learn critical what are the benefits of using point of care ultrasound as an imaging tool in intensive care? Sachin, sir.
So, good evening, all, and thank you for having me here. So, I work as an intensivist, and I've been using point of care ultrasound for let's say around 15 odd years now. And it's like a stethoscope for me. So, what we do as an intensivist is on our rounds, the ultrasound machine also takes the round. So, every patient is being evaluated. Uh, Head to toe. So a patient who is getting admitted to the intensive care unit. Now, let's say any patient who is coming to the intensive care unit with query diagnosis of hypertension, and you don't know what's the source. Is it a septic source? Is it a cardiogenic source or anything else which you don't know? What we do is we do an head to toe ultrasound. Starting from first, we look at our lung part. So we look at various signs of lungs, so lung sliding, effusion, pneumothorax, other things. We do a detailed echo. We look at our abdominal scanning. Basically, we want to look at sources. So we look at the liver structure, renal structure, splenic structure, what is the bowel motility, and then we look at our DVT. Now, once we establish a diagnosis that let's say this patient has a consolidation to start with, you start your management. What ultrasound helps is now it becomes a monitoring tool. You do it on a daily basis, or if you feel the patient is deteriorating, you can do it then and there to see is there a new additional finding to what finding you had earlier. So here it becomes a monitoring tool, and this is what we have been doing it for last many years. This is purely diagnostic part. Then comes the therapeutic part. Therapeutic means, see, central lines are like bread and butter of all intensivists. They are doing it through ultrasound guidance. We all know that they are being included as quality indicators. In West, if you are not putting a central line without the help of an ultrasound, your actual degree could be compromised, right? So in NHS, if you look at the UK health quality indicator, it's mandatory there. In India, it's still not, but we all know that all lines have to be put under ultrasound guidance. Coagulopathy has now become a relative, I will not even say contraindication, it has become a precautionary measure. So coagulopathy should not stop somebody from putting a line if you're using ultrasound. We do a lot of pleural tappings, ascitic tappings, pigtail catheter insertions. Now, because I am doing ultrasound for quite a long time, we do a lot of pigtails as in pancreatic drainages, transgastric drainages, abscess drainages. So it depends on the expertise and the comfort which you have. So from diagnostic tool to a monitoring tool to a therapeutic tool. And this is what point of care has brought us in the intensive care unit. Mostly it is very, very useful when you're looking at pulmonary and a cardiac issue. You can monitor your patients, you can guide your fluid resuscitation based on this. And what I understand will be the part of this entire talk. So I'm not going in that detail, but fluid resuscitation is the very important aspect, and ultrasound has been exploited maximally there in intensive care.
So, Dr. Sachin, going into that direction itself, when we say that monitoring and what we discuss is critical care is more or less about a fluid management, how and best way we can either dry the patient, either fill the patient, and try to monitor the fluid balance. So there are two things which I would like to ask. Number one is, what in your way is the best way to assess the fluid? And second, the paper which we are going to discuss is about the IJV, whether IJV ultrasound takes any role into an fluid assessment or monitoring or therapeutic ways.
So see, earlier it was thought that if you are measuring IVC, and let's say the IVC is collapsing. So there are papers which earlier came with said if the IVC is less than 1.5, your CVP is between 5 to 10. If it is around 1.5 to 1.8, your CVP is around 10 to 15. If it is more than 1.8 or 2, your CVP is 15, and don't give fluids. So the interpretation was like that. Now there are a lot of papers which have come which said, because IVC has earlier, which was looked at as a dynamic indices of resuscitation, has actually migrated into a static index of resuscitation. So what we do in clinical practice, IVC is not the sole parameter. What I do is I first look at the lungs. Are they wet? Are they not? So when I say wet and not, very, very layman language, if I have to put it in an ultrasound language, we talk about, are there A lines? Are there B lines? Are these B lines because of pathology, or are these B lines because of leaky capillary? That is one. What is the cardiac function? And in cardiac function, I categorically look at velocity time integral. So when I say VTI, because that's a surrogate marker of your stroke volume. And if you look at the Frank-Starling principle, you increase the preload, your stroke volume should increase. So you know what is your VTI, and classically a VTI of around 20 and above is what we say is near normal, which represents a good stroke volume. And then the third parameter that I look at is what is my IVC and IVC variability. Now, this is the toto that I take. Once I have seen that, okay, my VTI is less, my IVC is collapsing, my lungs are dry, which tells me probably my patient is in the ascending part of the Frank-Starling. I will give him a fluid bolus, which could be around 200, 300 ml. What is my VTI again? So this VTI variability tells me, is my patient going to tolerate further fluids or not? And this is how we resuscitate these patients. Now, let us say I'm not able to see the IVC for any XYZ reason. Let's say the patient has undergone an abdominal surgery. He is not allowing me to put the probe, or their staples or their suture. Patient has some subcutaneous emphysema through the transhepatic window. So again, it blocks my IVC visualization. This is where your IJV has come into the picture now. So IJV, there are earlier, we thought that IJV is the classical representation of the venous system, as in how do you look at the RA system. Now we have IJV. So the only problem with IJV is this is a superficial vein. So, enthusiasts would put a lot of pressure on the IJV. Oh, fine, I want to see the IJV. And then they actually disfigure the entire diameter, because the calculations are based on diameter, right? So the only precaution that we say, if you want to look at IJV, it has to be as gentle as feather. You don't put a lot of pressure, because you want to look at the variability in the diameter. That is one. People have also looked at the carotid artery Doppler, which is again a very, very good marker in terms of looking at your cardiac output. And these are validated to certain extent. There are a lot of, I will say, DNB theses which have come out on similar topics. Two of my students have published recent articles on carotid Doppler and IJV variability. And IJV variability is now looked as a good surrogate marker. But if I have to compare head on head with IVC, I will still take IVC as a better marker of a venous system or a preload dependency as compared to an IJV. But yes, you can look at IJV also if you are doing it correctly. So there are various ways you can look at IJV collapsibility, IJV diameter variation. Then you can look at the ratios. You can look at the distensibility indexes. So there are a lot of indices. And we say anything which is more than around 12 to 14%, the variability, it represents that this patient is preload dependent, right? This patient should benefit from a preload administration, which means a fluid administration.
Good. When we discuss about the future direction of point of care ultrasound, how far you feel so that as an intensivist, the ultrasound is going to go? Probably we have reached from, as you rightly said, we have removed the stethoscope and taken the probe in hand. How far and how best? This is first question. And second question is very controversial, that how we are going to judge the finding by different operators, because it's clearly sometime it is operator dependent thing, where you have to as like somebody will keep a probe little tighter, somebody will this side, how it is going to affect the future?
So, see, the future will be looked into two aspects. One, the safety of managing your patient. See,
Yeah.
when I was using stethoscope, remember this, if you are putting it on a chest and you say, this is Ronchi that I am hearing, right? It is only you who are hearing a Ronchi, right? If I am standing at the bedside, I have to believe what you are hearing. So again, this was an inter-individual variability. We were still looking at an inter-individual. Now you have a visual gratuity associated with ultrasound. If I say these are B lines, if there are 10 people standing on the bedside, everybody will see a B line unless and until there is an issue. You will say, no, this is not B, this is A and XYZ. But there is a discussion module which is available because it's a visual gratuity that you are getting. Two, medico-legally. Medico-legally, this is the future. We will have issues. We all know that in one of our very senior intensivists in Mumbai was sued for putting an ultrasound, for putting an intercostal tube in 2002. Remember when there was no ultrasound, the judgment came that it had to be put under ultrasound guidance. And we are talking about a case of 2002, 20 years back. So if the judge, if the lawyers and the judges are presuming that this is a quality indicator and one should use, so that is where this ultrasound assessment comes. Now, how to reduce this inter-individual variability? See, inter-individual variability is bound to happen. There is no doubt about it. What we do is you have to train people accordingly. There are fellowship courses which are running in the country. There are a lot of, these workshops which are running, and then the in-house on-job training has to be there. There has to be a mentor-mentee concept which has to be percolated. What I feel is if you have doubts, let's say you are doing an echo and you feel this is a 25% ejection fraction. Please ask your cardiologist who will be doing an echo, and if there are contradictory findings, you feel it is 25, he says 50, you have to see why is he saying 50, because when it comes to echocardiography, yes, he is a higher competence than you because he has been doing it for ages, right? You have just started your practice in terms. This is where you learn. With time, the inter-individual variability comes down to a level which is manageable and which is safe, and which has happened, for example, in my unit when my juniors started learning ultrasound, when they were totally naive, the A lines and B lines, they all were confused about what they were saying. The ejection fractions were all haywire. With time, with training, with looking at what we are doing it, that inter-individuality gap is reducing day by day. Right. So I would say it's an on-job training. Every day you have to train the same way how you ventilate your patients, right? You ventilate, the head will ventilate in a different manner. The newer comers will ventilate in a different tidal volume, different PEEP, different I's to E ratio. That is the inter-individual variability that you reduce. But this is the future of intensive care. This is the new armamentarium, and one has to accept that this is what will make your life easier, more comfortable, more realistic.
Thank you. Now moving forward to Dr. Karthik. Dr. Karthik, what we discussed about is that we are going towards the echocardiography in critical care and then moving to an artificial intelligence. Discussing about that, I was just using a day before a sonography machine where I have put a 4-chamber view, and that gives me an ejection fraction, my IVC, my diameter, my VDP, everything. I would like to know from you that in two aspects particularly, one is in sonography and second in CT, how we are gaining into an AI, what help the AI is getting into us, and what is future, how it is going to affect our management day to day. Like in CT, what we see every time is that we have an scan where we can see the good penumbra, and according to that we do thrombolysis. What is next, and how do you see the AI in future? Dr. Karthik, please.
Yeah. Good evening, everybody, and thanks Tushar and Rahul for the invitation, as well as Pratima. So it's a great question because AI is the way forward, as you can see in all walks of life. So why not in imaging and why not in medicine? So again, there are two different ways to look at AI both in critical care and in day-to-day practice. So how I would look at it is there are two ways to use it in your practice. One would be you have a preordained or a predefined process with a set of algorithms which allows you to go on a particular pathway of clinical care and allows you to refine that process again and again and again. So, for an example of that, what I mean by that is you take a pulmonary nodule, for example, a simple thing as you take a pulmonary nodule either on a chest X-ray or on a CT, and you load thousands and thousands and thousands of scans and you create a convoluted network which allows you to identify a nodule based on numerous criteria which are predefined. For example, size, morphology, shape, irregularity, relationship to the surrounding structures. So that would be the standard line of AI which is happening currently, simply because the amount of neural input which is required is substantial. The second way, which is probably going to be the way forward, is for allowing AI or convolutional networks to not work within predefined networks or algorithms. Now, what I mean by that is today you have a battery of supposedly 20,000 X-rays and or 20,000 CT scans, and you run it through an AI and you say that you create your own patterns of recognition. Are you understanding? So not the input is no longer man-made, but you allow the computer to actually define the own algorithm and parameters, which is going to allow what is offset, what is the standard deviation? Is it plus or minus 0.5? Is it plus or minus 0.1? Is it going to be 1? Now, why this is becoming so important is in this current generation is, and that was touched upon in the prior lecture briefly, is that when you're doing imaging, and you're saying supposedly you're looking at the patient for an imaging in a stroke, and you find the patient does not have a stroke but now has got an incidental finding. Now what happens is AI is going to be allowing us to not waste our time of rummaging through those thousands and thousands and thousands of data sets by telling, okay, this is an incidental finding, you don't waste your time on clinical care right now on this because this does not impact your management. In CT, this is really useful simply because we are looking now for an infarct, and now you pick up a meningioma or you pick up a brain tumor sitting somewhere else, which is like a mimic of a particular condition. The advantage of CT in AI is it's more easily reproducible, and therefore your inter-observer and intra-observer variabilities of the reads can be minimized very, very, very easily. The challenge with an ultrasound is being able to generate the same image for AI to replicate each time you're scanning the same patient. For example, I'll give you this. If I were to scan a patient, supposedly you say at 8 a.m. in the morning, 6 hours fasting, and then within 1 hour after breakfast, AI will give you a different echo texture of the liver. Simply because there is change in portal flow, there's change in hepatic arterial inflow, and there's a deviation in the hepatic venous outflow. Simply because the patient has probably had a meal and come in. As simple as this. This is a physiological variation. So in ultrasound, it is AI to come in will only happen if your standard deviations are going to be significantly much more wider as compared to what happens in CT. And that's just simple. That's why they keep on saying it's observer dependent. Yes, when you're doing it real time, you can have a discussion because you're going to have a larger area to show actually what is happening on a screen. But if you're going to capture 10 defined data sets and said, okay, I'm doing this at 8 o'clock. I want the next seismologist to come and generate the same set of images. It's next to impossible to be able to do this. It's not going to be possible. CT, very easy. You can generate the same kind of images again and again and again. And that makes AI a very robust tool in CT. That's why you're seeing it happening in stroke. Why? Because the protocols don't change. The patient, more or less, the parameters for stroke are very well defined. You know what your stroke volumes, you know what your mean transit times, you know what are the standard norms for your CBF and your CBVs and your TTPs, which is your time to peak, and you have your standard deviation, and you get the same set of images each time you scan the patient. In ultrasound, you can just not do that. So that's where the challenge with is in AI, in terms of AI in ultrasound. CT and MR, it's not so much of a challenge.
Good to know that. So, in this situation, what we discuss is about how AI is transforming. I have a question to Dr. Rahul Seth. Sir, how it is going to impact AI per se? AI is going to impact to the procedural acumen or procedural accuracy in your case, sir?
Honestly, in intervention radiology, I don't see so much of AI, which will mean so much benefit of AI for us, because ours is mainly based on doing the procedure itself and diagnosing on table. Where it will help is what Karthik rightly said, is that it can help to pick up things on just maybe a CT or an MRI and tell us, okay, this is the artery you need to go to, or this is the area where the bleed is coming from, or this is the tumor artery supplies coming not only from the hepatic arteries, coming even from the intercostal artery. That may help to figure out if normal CTs can't do. But I've not seen much data on or read any papers of AI much helping us in interventional radiology per se, because that's more a skill-based level of how you do the procedure, how you analyze on table what's happening. So being more of a surgical, sort of more like a surgical branch, I don't think AI has much role to offer other than picking up things to help us aid doing the procedure itself.
So the next question comes to you, Dr. Rahul. We are talking about the trauma care. In trauma care, we have been going with a lot of trauma with involved pelvis, splenic trauma, liver trauma, and internal organ and extremity traumas. From here, how we are going to fit the situation into a scenario where a trauma is called to be a protocolized. How do you see a protocolized care with an intervention radiology being a part of it? Like whatever studies I have read, they say that IR should be within 30 minutes of near around the hospital, should be able to achieve the actual hemostasis and see how things are. So IR in trauma, how do you see it, and how far you have gone through it, and what is your experience in that?
So this is an excellent question, and I read this paper which you said, and I think trauma should be treated now like a stroke. So how we are looking at stroke, people rush in and get everything done, and we have stroke protocol or we have PAMI protocols. I think trauma is something we have wasted a lot of time in. I think all of you will agree in the ICU. We spend a lot of time first trying and getting things done in the ICU itself. Yes, if it's obviously an emergency thing and you have to get some pressures up and you have to start everything, I'm not denying it. But if you know there's a bleeder which is occurring, you know let's for example, it's a pelvic trauma, and you've done a CT will obviously be done mandatorily in a pelvic trauma. There's no question about it. And you'll see that there is frank contrast extravasation coming from a branch, or you see that there is a hematoma more than nearly 500 or 600 or even up to a liter sitting in the pelvis. That means you know it's more likely an arterial bleed which is occurring. Patient is a little unstable. Instead of wasting time and taking the patient back from the CT scan to the ICU, I think that time it should be activated immediately, that the lab has to be kept free. Patient is going for a CT, and then from there, if you see any bleeder, immediately take the patient to the lab and embolize that offending artery and try and stabilize the patient. So I am a strong believer that in trauma that we should treat it literally like an acute cardiac event or an acute stroke. And time is of essence here, and we should get into it as soon as possible. Yes, resuscitative measures which need to be done can also be done simultaneously while you're doing an imaging or while you're shifting the patient, or even in the cath lab. You can even start all the resuscitative measures while you're in the cath lab itself. So that's how I would look at looking at trauma. And yes, IR normally are now quite a few of them in the city. So getting an IR in a trauma case should not be that difficult, at least in a city like Mumbai. And you will have someone available within the next 20-25 minutes with no issue at all. And that should not be a problem. Only thing is, maybe in Reliance it's not such a problem. We have 3 labs, but in certain other hospitals, where you work, you can have a single lab and sometimes there's an ongoing case going on. Then it's very difficult to dislodge a patient who's undergoing a procedure from the thing. So that's something where obviously hospitals have to take into account. And if you're in a major trauma center where a lot of trauma work is coming, I think it should be mandatory that you should have two labs, two cath labs in that hospital.
If I may add something to Rahul's thing, I think I think we've all worked abroad, and some of the best trauma centers actually have their own inbuilt CTs and their CAT suites in the
Yes,
ER itself.
in ER
And
itself.
yeah,
Yeah.
ER itself. So they walk in basically. They get the CT done, and the CT makes an emergency or a critical finding like a stroke with a major vessel occlusion or a bleeder, like Rahul was just saying, and the patient just goes straight into the cath lab in the
Yes.
ER itself, and it's sorted out then and there. I think that could be a future possibility in our own hospital or a setup like ours, which we should consider.
Completely agree.
Completely. That's a definite way to move forward. I think so. We do have scan, but we don't have the cath lab just beside the cath lab. Dr. Sachin, your view on how because we have not spoken about the AI with you. So your view on AI, particularly on ultrasound, cardiac ultrasound, how do you see it?
So see, the modern machines, the newer machines which have come up, they have AI enabled. So if I look at GE when you go, right, so it has an AI enabled thing. So yes, it helps. It helps in terms of trainees as well, because once you're doing an echo, it automatically calculates the ejection fraction. The only thing is, see, it will calculate the ejection fraction even if your image is not appropriate, right? Because it's once it sees a 4-chamber dimension, it will start calculating an ejection fraction. What we would like a good 4-chamber, so that is what we, if I don't have an AI on that particular good quality 4-chamber view, I would calculate ejection fraction. So even if I'm incorporating my AI into the machine, the quality has to be there. So it's like a tool with a fool is still a tool, right? You have to know how to use that tool. So you need to generate the appropriate image for the AI to interpret that image correctly. AI will still interpret the image. AI will still interpret the ejection fraction, even if I don't have a correct 4-chamber view. So that is what is the problem is there. But yes, once you know the technique of doing an ultrasound, AI with time becomes very, very intelligent, right? The sensitivity and I would say the correctness of predicting these cardiac measurements improve with time. Secondly, the best part is if you're looking at, follow up, if you're looking at the trend, if you want to look at that, what was my ejection fraction 3 days down the line and what it is to, this is where your AI comes into use. So when you go, you look at your IVCs, you look at your ejection fraction. So you need not do those Simpsons and, those more technical things which are very difficult for people who are learning, right? Because they find it very complex that how do you take that 2-chamber view, draw a cylinder and all that stuff. This is where the AI is useful. And yes, in times to come for monitoring, AI will be helpful. For procedural guidance, I still have my doubts that how much useful will AI be there in terms of procedural guidance. But yes, for basic assessments and monitoring, AI will help us out. But still, the technicality of doing the correct scan is still a human thing, and one has to master that art.
No, if I may just add one more thing, Tushar.
Yeah.
See, how much ever you add AI, like how Rahul and my other colleague was just mentioning, you still require a human interface to basically have the final checkpoint. Because an AI is as strong as the input, and the input is by a human mind only. That's what. So most of the convoluted networks right now are based on human interpretations of particular things. The day AI really comes into play when you let it go free and you don't have boundaries, and then it has its own pattern recognitions. That's where human interference is going to come less. And there it's going to be a truly AI. Right now, the AI is governed by what we input. So, for example, like we are doing quantitative imaging. quantitative imaging, today I can make a number, like Rahul will say very clearly in stenosis, that vascular stenosis, IR is the best. So if he says it's 90%, CT will go plus or minus 5 to 10%. But the IR is the best in this. But today, as a CT radiologist, I can easily fudge my measurements, plus or minus on either side. That's what I'm trying to tell you. With any other form, the AI will improve those, but that improvement is still finally going to be judged by the clinician or the radiologist or the IR guy only. So that's how the system is currently.
Thank you. And probably with the time constraint, the last question to Dr. Rahul. What are the post-intervention monitoring typically for a procedural perspective you would like to have in intensive care? Just a brief about it.
You're asking just for specifically for any intervention or just basically trauma intervention?
No, not a trauma, sir. I'm just asking as in any intervention where you have been with the arterial system, venous system, or any other system. So what exactly you want to have as a, like, if we form a protocol in future, that this is what as an any intervention protocol should go. That's how we are.
Fantastic. So that's the most basic thing is something which creates the maximum problems, which we in all of us, not only meaning including me, including the everyone, we only look at the numbers on the screen. I have seen in the last 5 years, not many people start looking at the patient. Now, when you're doing an intervention, we are going through an artery. When you're going through an artery, you're putting a sheath. Now, if you're doing an intervention, sometimes in a major intervention, like if you put an aortic graft, you're using big side sheets. We have to first look at the access site. The first thing in the ICU, any of the post-intervention, please look at the access site. You can do an excellent intervention. Your access site develops a hematoma, pseudoaneurysm, or worse, it develops a thrombosis. All good which you have done for your intervention is going to be negated in that next 24 hours. I think all of us have an experience of it. So sheath removal, clot which has formed, or a dissection, God forbid, occurs, it has to be identified early. If it's identified early, you can take appropriate action. You can get that clot out. God forbid, it's going to happen. It's going to happen with every interventionist, every high volume ICU. You're going to have complications, and we have to accept it. But the thing is, we have to identify it early. If you identify a clot early, it can be taken out by an endovascular method rather than doing a surgical method. You can aspirate the clot out. You can give a low dose of a drug and dissolve that clot if it's possible at that time. But if you're going to identify it late, then it becomes a surgical intervention. Sometimes you require fasciotomies. And we have seen not simple, but we've seen patients going in for stroke and they land up with the thrombus in this thing. No one has checked the distal flow. So most importantly, monitor the access sites which you're going through, whether it's radial, whether it is femoral, whether sometimes it is brachial, whichever access site you're going through, monitor that. Monitor it for hematoma, monitor for anything, monitor the distal limb which is there, whether it's becoming cold, is there a temperature difference? And that is a clinical diagnosis. We don't have to keep on looking at numbers or saturations for that. Use your hands, check your pulses. If it's not there, always ask for an urgent Doppler. A handheld Doppler also is good, and then you can go ahead and treat. The standard monitoring, Tushar, which is going on in the ICU is excellent in, I think, in nearly all the ICUs. Obviously, we look at the parameters. Most importantly, any intervention, we need to look out for early infections. Those are something which we always worry about, especially if you're embolizing arteries. We are always looking at, God forbid, if patients can go into, sepsis or anything like that. So monitor for the infection parameters very, very closely and see that if patient has fever, don't ignore it. Treat the fever, get counts done if required, sometimes get cultures done, change the antibiotics. That has to be aggressive monitoring, especially in any intervention which you are going through. We're lucky now with skill and technology, things are much lesser, the complication, but especially in trauma patients, and especially any high-end interventions or complex aortic interventions, you need to obviously monitor for any bleeding which is occurring, God forbid, because of the procedure, or any thing which is occurring remotely. Sometimes you pass a wire and there's an artery which is dissected. Standard urine output which has to be measured. All those things we have to keep a strong watch on. But the main thing I'm telling you, I can't stress, we have seen excellent interventions, and we have seen access site complications which negate all good which we have done. And other than that, obviously standard monitoring of blood pressure, pulse, see how the response is going on antibiotics, and if all good, then the standard ICU care, which I think all of you are much better than on talking about it than I will. But from my point of view, this is the basic thing which I require. And obviously seeing the medicines which go on, checking your anticoagulants are going on well. If you're doing a if you're doing anything which has a clot, if it's a venous intervention, seeing that the INR is fine. If I'm doing an intervention like a thrombolysis, checking the PTT 8 Ali, seeing that it's maintained between 60 to 70 with the heparin going on, adjusting it accordingly, checking for bleeding and watching early signs so we can take appropriate action.
And just adding on what Dr. Rahul said. So see, if you have an arterial sheath in C2, right? And once you have decided that, yes, I will take it out once your APTT is, let's say the ACT is less than 160, 180, whatever number you are comfortable with, please attach a pressure bag with either saline. Don't just even wait for that 4-6 hours that fine, I have to take it out, because we have seen clots being formed. We have seen dorsalis pedis, pulses going away. We have seen the limb getting cold. So don't be shy, even attaching for 4 hours, 6 hours. What is that?
Fully agree with you.
Irrespective of that.
Yeah. I think Tushar has worked with me, so he knows every note of mine. There'll be transduce the sheet, transduce the sheet, transduce the sheet. So I think that's mandatory, which goes from my protocol in all in every this thing. But still, we see it's not happening.
Yeah,
so,
still people try to, what we experience. People will do an intervention, let's say for lakhs of rupees, and they want to save that typical 1,000 rupee by just not opening that the cost constraint. I don't see any cost constraint there.
No,
I think
definitely not.
It's a bad move.
No, I agree with your point and very well taken. The access side complications are the maximum which we see in the ICU or anything, because of not for anything else. It's because everybody's looking only at the big picture. No one is looking at that small little groin which we have gone through, and then you can have disastrous complications. And I can't stress more on that right now.
Good. Good discussion. Thank you, Dr. Sachin. Thank you, Dr. Karthik, and thank you, Dr. Rahul.
Thank you. Thank you, everybody, for the opportunity.
Thank you.